Hello and welcome to the next lecture, and today we are going to discuss about the molecule which is the next autocoid of amine category. It is 5-hydroxytryptamine, also known as serotonin. Historically, serotonin was originally identified as a substance which was present in the serum of the clotted blood, which was able to produce vasoconstriction, and they named it serotonin. Similarly, there was another molecule which was identified to be present in the enterochromaffin cells of the gut mucosa, which was able to cause smooth muscle contraction, and they called it enteramine. And in 1950, they found out that both these molecules chemically were 5-hydroxytryptamine, and as per the IUPAC name, they were beta-aminoethyl 5-hydroxy indole derivatives. Later on, they found that both these molecules are same, and they called them 5-hydroxytryptamine or serotonin. Let's look at the life cycle of serotonin. Serotonin is obtained from the amino acid tryptophan, and tryptophan is obtained from the diet. So tryptophan basically is the dietary precursor of serotonin. Tryptophan is converted into 5-hydroxytryptophan by an enzyme tryptophan hydroxylase, and this step is the rate limiting step in the reaction or the synthesis. So this is the rate limiting step in the process. And in the same process, tetrahydrobiopterin is converted into hydrobiopterin. So there is a chain of reaction that takes place, but to simplify it, we can put it like this. So after this rate limiting step, the hydroxylation of the amino acid tryptophan takes place, and this hydroxyl group is added. This molecule undergoes decarboxylation here by an enzyme 5-hydroxytryptophan decarboxylase. This is a common decarboxylase enzyme which is not only involved in the decarboxylation of tryptophan but also of other molecules, for example dopa, in the synthesis of dopamine. Once decarboxylated, the molecule is converted into 5-hydroxytryptamine, commonly known as serotonin. This serotonin is stored inside the cells where they are synthesized, or inside the neurons of the serotonergic neurons where they are also synthesized, and then released upon the activation and acts through its receptors, which are 5-HT receptors having multiple subfamilies. After it is acted upon, it is metabolized by an enzyme known as monoamine oxidase. Monoamine oxidase or MAO enzyme, as you already know, has two types, A and B. 5-HT is acted upon by MAO A, which oxidizes this amine group and converts into an acid group, and it becomes 5-hydroxyindole acetic acid. This reaction, this molecule undergoes rapid excretion in the urine. Alternatively, this molecule can also be acted upon by another enzyme known as dehydrogenase and converted into 5-hydroxytryptophan. Remember that this molecule, that is 5-hydroxyindole acetic acid, this molecule has a clinical relevance that increased level of this metabolite is a primary diagnostic marker for a disease or a condition known as carcinoid syndrome. Carcinoid syndrome is a clinical manifestation in which there is release or dumping of high amount of 5-HT through neuroendocrine tumors. These neuroendocrine tumors specifically dump 5-HT when they have metastasized from gut to liver. So this clinical manifestation can easily be diagnosed if there is 5-HT dumping or not by measuring the 5-HIAA, that is 5-hydroxyindole acetic acid levels in the urine. This enzyme 5-HTP is also known as aromatic amino acid decarboxylase. That means this enzyme is involved in the decarboxylation of all aromatic amino acids. Let's look at the anatomical distribution and cellular storage of 5-HT. 90% of the 5-HT is stored inside the enterochromaffin cell in the gut mucosa, whereas remaining 10% mainly lies in brain and platelet. and platelet. In brain, it is stored mainly in the serotonergic neurons and is available in the platelets through the blood circulation. It is important to note that 90% of the 5-HT stored in the gut mucosa is also synthesized there, whereas remaining 10% is synthesized in the brain, specifically in the raphe nucleus present in the brain stem. Platelets do not synthesize 5-HT, rather they obtain it via uptake when they are passing through the intestinal blood vessels. When they pass through the intestinal blood vessels, the 5-HT present in the enterochromaffin cell is taken up by the platelets into their cells, and from into the cells they are stored inside the storage vesicles in the cell, where there is an uptake into the vesicle through a specific transporter known as vesicle monoamine transporter 2. This same transporter is also present in the serotonergic neurons. So all the serotonin that is synthesized, it cannot stay in the cytosol because it will be hydrolyzed. Rather, it is immediately taken up into the storage vesicle with the help of VMAT2. Serotonin acts in the body through 4 major families of receptor, and these families are 5-HT1, 5-HT2, 5-HT3 and 5-HT4 to 5-HT7 group. Out of this, 5-HT1 receptor, 5-HT2 receptors and all 4 to 7 receptors are G protein coupled receptors, except the one, that is 5-HT3, which is a ligand gated ion channel, also known as ionotropic receptors. This receptor is responsible for rapid cation influx and thereby producing excitatory action. This is its primary mechanism of action. Whereas 5-HT1 is acting by decreasing CAMP level and therefore primarily produces inhibitory effect. 5-HT2 acts by increasing IP3 DAG level and thereby increasing calcium influx, and therefore this one also produces excitatory effect just like 5-HT3 receptors. 5-HT4 also increases CMP just like 5-HT1 and thereby causes excitatory effect. Whereas 5, 6, 7s, the 3 receptors which are all mainly located in the CNS, are responsible for modulatory effect. So they basically work by causing CNS modulation. CNS modulation means that they either fine tune or adjust the strength of communication between 2 neurons, rather than causing their own firing. So they do not cause their own activation or direct activation of neuron, rather they fine tune the communication between the other neurons. This one is GI type, this one is GQ type, the fourth one is GS type, and the 5, 6, 7s are either GS or GI. If you look at the subtypes, 5-HT1 has 5 subtypes A, B, D, E, F. C, 5-HT1C was later identified to be subtype 2, so it became 5-HT2C, which has 2 other types also, A and B. Ionotropic receptor is a single family, and so are 4, 5, 6 and 7. So what are the actions of different serotonergic receptors? Serotonin acts through its receptors in the CNS, where it is responsible for regulating mood. Mood includes anxiety, aggression, and depression. In addition, serotonin in the brain is a precursor to melatonin released from the pineal gland, and therefore it regulates circadian rhythm, though indirectly. Lastly, it also modulates pituitary hormone release because there are hypothalamic serotonergic neurons that are directly connected to the pituitary gland, and they modulates its hormone release. Second action is on the respiratory system, where 5-HT2A receptors activation produces bronchoconstriction. It is normally not seen, but it is especially a symptom of the carcinoid syndrome, where there is specific dumping of serotonin when the neuroendocrine tumor they metastasize to liver. In the platelets, serotonin is responsible for aggregation and clot formation and is known to trigger the process of hemostasis. Also in the brain, in area prostema as well as in the specific channel known as nucleus tractus solitari, collectively which form the vagal complex of the brainstem, specifically the dorsal part of the brainstem, it forms a structure which is a circumventricular organ. Circumventricular organ means that it bypasses BBB and therefore can directly sense the toxins and the chemicals which are part of the blood circulation without them requiring to enter through the blood-brain barrier. And therefore, these two specifically regulate the emetic response. And we call this area as CTZ or chemoreceptor trigger zone, which plays an important role in the chemotherapy or radiation therapy induced nausea. Please note that it is 5-HT3 receptors which are involved in this process of emesis and nausea. 5-HT2 and 5-HT4 receptors are known to regulate the intestinal motility, peristalsis and the intestinal secretions. So it is mainly a regulatory role of 5-HT2 receptors. On the cardiovascular system, 5-HT2A receptors are involved in the process of vasoconstrictions. The serotonin release and its action on the cardiovascular system causes vasospasm. This vasospasm is specifically noted in Raynaud's phenomena, which is a phenomena associated with Raynaud's disease, which is a peripheral vascular disease, in which the digits or the finger, they become numb and cold due to decreased blood flow caused by the vasospasm. This vasospasm has been noted to be caused by 5-HT. Also, it is responsible for coronary vasospasm and has been implicated in generation of the variant angina. Though it is noted that there is a role for another molecule, another autocoid of prostaglandin type related to prostaglandin, that is thromboxane A2. In addition, 5-HT1B and 1D receptors have been noted to modulate vasoconstriction in brain as well as neurogenic inflammation and therefore have been implicated in the pathophysiology of migraine. Let's look at what are the strategies for the pharmacological modulation of serotonin levels. Simply, tryptophan is the precursor, and therefore high tryptophan level will lead to increased serotonin biosynthesis as well as release. The synthesis blocker is a molecule parachlorophenylalanine, also commonly known as phencolene, which is an experimental molecule used to inhibit the enzyme 5-hydroxytryptamine hydrolase, the tryptophan hydroxylase, and By inhibiting this molecule in the experimental animals, it can cause 5-HT depletion, and can be used to induce hyposerotonemia in the experimental animals. Just to clarify, this molecules acts by directly inhibiting tryptophan hydroxylase. Second strategy, this was first strategy. Second strategy is storage blockage. We all studied that the serotonin which is synthesized must be uptaken into the cell and then into the storage vesicle so that it is not metabolized in this location. And that happens through VMAT2. Reserpine is a drug which can block VMAT2 and thereby prevent these vesicular uptake of serotonin and thereby increasing its metabolism in the cytosol, causing severe monoamine depletion. And the third strategy is vesicle release. As more and more serotonin is released from the vesicles and in the excessive quantity, there will not be enough receptor to saturate it and the excessive amount will be reuptaken, and before it can go back to the vesicles, it will be hydrolyzed. So while this strategy is vesicular release, it actually leads to depletion of 5-HT. Drug which can increase vesicular release and cause consequent depletion of 5-HT is fenfluramine. Other strategy of a pharmacological modulation is by targeting its uptake and degradation. As you know, before it can go into the vesicle, it has to be uptaken either in the neuron or in the cell, and the transporter involved in this process is known as SERT or serotonin transporter. There are drugs which are known as serotonin uptake inhibitors. They include non-selective inhibitors like tricyclic antidepressants, which can inhibit the uptake of both 5-HT as well as noradrenaline. They include drugs like nortriptyline, or there can be specific inhibitors of SERT which are known as selective serotonin reuptake inhibitors, and they include drugs like fluoxetine, sertraline, etc. because they are highly selective for 5-HT reuptake blockage only and not NA. Both of these class of drugs are used as antidepressant. In addition, the nortriptyline has also found an off-label use in the treatment of neuropathic pain. The next and the last strategy is inhibiting its degradation and thereby increasing the availability of serotonin. Also remember that in this case also, uptake inhibitors increase the availability of serotonin for its binding at the receptor site. And the last strategy which increases the availability of 5-HT is by inhibiting its degradation, and the major pathway of degradation is by MAO-A enzyme. There are two classes of drugs. One is non-selective MAO inhibitors which inhibits both MAO-A and MAO-B, known as prenylcypromine, or there can be selective MAO-A inhibitors like clorgyline which can specifically inhibit the degradation of molecules which are metabolized by the enzyme MAO-A like serotonin. Sixth strategy is by targeting the 5 serotonergic receptors using the agonist, and this has multiple clinical use. The drugs which are agonist at 5-HT1A receptors include drugs like buspirone, gepirone and ispapirone, or all drugs with suffix pirones, and they are partial agonists at 5-HT1A receptors and have been found to in the treatment of anxiety. They are anxiolytic or anti-anxiety drugs. 5-HT1B or D agonist can induce rapid cranial vasoconstriction and thereby can be used in the treatment of migraine. They are not used in the prophylaxis, rather for the abortive strategy for migraines, and they include drugs like 5-HT1B1D agonists like sumatriptan, zolmitriptan, or all types of triptans. 5-HT4 agonists tend to increase gastrointestinal motility and they are used as prokinetic agents. They include drugs like cisapride and rendapride. You can study more about prokinetic agents in the gastrointestinal drugs category of drug. There are some non-selective agonists of 5-HT receptors also. They include LSD. They are hallucinogens and they tend to produce their hallucinogenic effect by binding to 5-HT2A and 5-HT2C receptors. These are illegal drugs. LSD means lysergic acid diethylamide. They are psychedelic molecules commonly known as by the slang names like acid or Lucy. In the last class of drugs which can be which target 5-HT are the 5-HT receptor antagonist. This is the seventh strategy for pharmacological modulation of 5-HT. And the most important drug which acts as the 5-HT antagonist is 5-HT3 antagonist. That is the drug which inhibits the ion channel. This drug is ondansetron, and these are clinically very commonly used antiemetic drugs, and they are undisputed gold standard treatment for chemotherapy-induced nausea and vomiting. You remember we studied that CTZ is activated by 5-HT. So they target this and decrease the nausea associated with the chemotherapy and the radiotherapy or the radiation therapy. Other than that, 5-HT3 antagonists have been used in migraine prophylaxis, mainly by targeting 5-HT2 receptors, that includes drugs like methisergide, 5-HT2 antagonist, as well as pizotifen. These are the two 5-HT antagonists used in the prophylaxis of migraine. Secondly, for the management of carcinoid syndrome, as it involves a lot of 5-HT release, and the drug which is used is cyproheptadine, which is a 5-HT2 antagonist. 5-HT2 antagonist. Remember, cyproheptadine, in addition to being 5-HT2 antagonist, is also an antihistaminic drug. And if you remember correctly, then it is also used as an appetite stimulant that we studied in the lecture on histamine, specifically in young children who suffer from anorexia. 5-HT dumping syndrome can be treated by either 5-HT3 antagonist, that is ondansetron, or with 5-HT2 antagonist, cyproheptadine. Atypical antipsychotics, which are used in the treatment of schizophrenia, they also have 5-HT blocker effect, in addition to their anti-dopaminergic effect. So this is all about the serotonin and its biosynthesis, storage, degradation, receptors, and its physiological and pharmacological relevance. Thank you.